It is June 2nd, 2017, and we are in Salt Lake City, Utah with Dr. James O. Mason. Dr. Mason was in the Epidemic Intelligence Service class of 1959 and was the director of the Centers for Disease Control and Prevention from 1983 to 1989. My name is Karen Torgaley, and I will be talking with Dr. Mason for the Global Health Chronicles Oral History of Polio project. I want to say welcome, Dr. Mason, and thank you for being here today.
It's wonderful to be here.
I think maybe we could start by having you give us a little bit about your background, how you grew up, where you grew up, what your family was like, some things like that first.
I grew up in Salt Lake City, Utah. I had, of course, two parents and two sisters. My mother was a nurse, and so she was a working mother, and my dad was an accountant. And we lived, I guess about 2 miles from where we sit today when I grew up.
How did you get interested in medicine?
I was always interested in plants and animals, and I had a lot of pets and just enjoyed living things. My mother was a nurse, and often I'd walk over to the hospital and walk home with her after school, because where I went to elementary school was right next to the hospital, and so through her I had a great association with medicine. But as I grew older, I became more and more interested in engineering, and when my mother tried to get me to go into medicine, I said that's the last thing I really want to do. But later in my college career, I began to think that I'd rather work with people than with materials and mathematics and things of that nature, so I changed my mind and followed her advice and got into medical school.
And where did you go to school?
At the University of Utah School of Medicine.
When you were in medical school, did you happen to take care of any polio patients, or when you were growing up, do you remember about polio and how it affected people?
I remember well polio, because when I was growing up, this would have been, I was 12 in 1942, and at that time there was grave concern. People were worried about polio. Every August or September, it seemed, they closed the swimming pools. They wouldn't let kids congregate at movie theaters because they were fearful that we would spread polio from one person to another. So it was a disease that parents feared, and through their fear, all the kids were worried too about the disease. Our friends, schoolmates, and others were coming down with polio, and some of them had been very seriously crippled.
And at the time, they didn't know what caused it, is that right?
Well, my mother taught me that it was caused by what she said, we think it's a virus, but that's about all we knew, and we really didn't know how it was communicated, although they thought people coming together, and they closed the swimming pools because they thought that swimming pools might be transmitting the disease, but they really cut back on all close communication of individuals, gatherings when an outbreak occurred, and it was always in late summer.
Mm-hmm. And later, when you were in medical school and residency, did you take care of polio patients? Do you remember?
I entered the University of Utah Medical School in 1954. And as a freshman, I had a brief rotation on pediatrics. And at the old General Hospital in Salt Lake City, which was the teaching hospital at that time, there was a great big ward. And in it were 30, maybe 40 iron lungs. And every one of those huge iron lungs had usually a child or an adolescent inside, and you could hear them pumping away as they breathed for those patients that had been put in the lung. So my first experience was polio on that kind of a scale.
Must have made a huge impression.
It did, and a lot of people were afraid of polio at that time.
And that was 1954, you said.
1954.
And the next year was when the vaccine came out. Do you remember that?
You know, I have little recollection other than I did know that they were doing a test to see whether the vaccine was safe and effective. That was in the newspapers, and it was big news at that time. And I just have a very vague recollection that something like that was going on.
When you were in medical school, did you know then that you wanted to go into public health?
No, I did not. I thought I wanted to be an internist.
Do you remember what it was that influenced you to go to change that?
Well, it was really EIS and CDC that caused me to have a change of mind.
And how did you get involved in that?
I was deferred during the Korean War. I had a draft obligation, but because I'd been accepted to medical school, that was postponed. When I completed my internship at Johns Hopkins Hospital, I was now due to pay back, and I, through the Berry Plan, had a choice of either the United States Public Health Service or the United States Navy. The Navy wanted to put me on a cruiser that would sail out of San Diego. My father was an officer in the United States Navy during World War I, and that was attractive to me. But by that time we had 3 small children. I'd been away from home a lot during my internship, and I thought maybe it would be better to go into the public health service where I could serve and be near my family. I applied to the Indian Health Service because I was well acquainted with that part of the public health service, and I would have liked to have worked on one of the Indian reservations. But I heard nothing from the Public Health Service or Indian Health Service and was just ready to take my Navy physical when out of the blue Dr. Bruce Dahl called and asked me if I'd like to become part of the Epidemic Intelligence Service. I asked him, what is that? And so he patiently explained to me what EIS was, what CDC was, and offered to fly me down to Atlanta for the April EIS conference. So I went down there, saw what was happening, and they offered me a position in the class that was starting that June, and I was delighted to accept. He had found my application to the Public Health Service somewhere in Washington. Apparently the Indian Health Service had never received it, and it was just lying there, and he felt maybe I qualified to be an EIS officer and that I might be interested in taking a position that had been vacated because one of the EIS class of 59 apparently hadn't met the physical qualifications, and suddenly at the last moment they had a vacancy.
That was a fortunate thing to happen for all of us.
Well, particularly for me.
When you came then, you moved your family to Atlanta, then it was 1959, is that right?
Well, I didn't move them to Atlanta because I wasn't sure we were going to stay in Atlanta. So I came for the course, which was for 6 weeks, and then when I was selected to be the chief EIS officer after the 6-week course, then I moved the family to Atlanta. I had driven them home in Salt Lake from Baltimore, and they stayed there while I was taking the EIS course.
Do you remember how long the course was then?
It was 6 weeks at that time, as I recall.
Tell me about some of the teachers you had, because I know you had some really big names in public health at the time.
Alex Langmuir, who headed the epidemiology branch of CDC, was the #1 teacher. Of all the teachers we had there, he was charismatic. You just were on the edge of your chair every time he lectured. He always had wonderful examples as he taught principles. He used the case history method of teaching, and so he was the #1 instructor in terms of the time. He was willing to give that much time to this group of about 25 new EIS officers. We had other CDC personnel. I remember Robert Surfling and Ida Sherman that taught biostatistics. And then we had a whole series of people that came in from outside CDC. And they were top-notch medical school faculty, public health experts, just to list K.F. Myers, for example, who was an expert in zoonoses, and they had veterinarians. We had the cream of the crop. It was one of the best educational experiences I've ever had.
That's reflected in the notebook that you donated to the CDC Museum, too.
Well, I kept it. It was such a good notebook until I donated it.
Yeah, so we were very happy to get that. When you had biostatistics, you had Dr. Surfling and Ida Sherman.
That's right.
And how do they make statistics interesting?
They also were able to illustrate with cases, and we actually did problems and exercises that were related to epidemiological investigations and how one showed significance, association, and we could see how absolutely vital it was that not just to collect data, but one had to do an analysis of that data. And they helped us see what went into such an analysis and how interesting it was, because you really couldn't make a conclusion until you'd done the biostatistics and the mathematics and showed that the differences that one was observing was statistically significant.
Mm-hmm. And what tools did you have to work with?
Now we all have our cell phones, our handheld, our computers. We were using slide rules and electronic calculators that would add and subtract and divide and multiply. And they were just starting file cards. And we had something that was called a McBee card. And it was a card with little holes punched all around the periphery of it. And one would use an ice pick. And by punching out the right hole, you could get correlation. And so it was it was a computer by hand.
Isn't that interesting? When you got your assignment as a chief EIS officer, how were you chosen, and what can you tell us about that?
Well, I became interested in the job because H. Bruce Dull, who had recruited me into EIS, was serving as the chief EIS officer. And I saw what a great job he was doing and how interesting it was. And we got our assignments at the end of the course, and we could put down a selection of 3 positions that we would be willing to work in. And I put down Chief EIS Officer as one of those positions, and apparently I was the only one that even listed the job. So I got it.
You got it. What was that like for you? Can you sort of walk us through what a day might have been like for you in that job?
Well, first of all, I really wanted the job because it allowed me to work very closely with Alex Langmuir and the other key individuals within the epidemiology branch. And I thought maybe some of their enthusiasm and brilliance could rub off on me if I spend enough time with them. So I really enjoyed working with Alex, Russell Alexander, D.A. Henderson, Bruce Dahl. He was still there in another position. And it allowed me not only to keep in contact with all of my class, all of the graduates from that EIS class went out into the field or stayed in Atlanta. And so I had an ongoing association with them as well as the class of the year before. And it also gave me opportunity to get acquainted with other parts of CDC, laboratory branch, technology branch, everything that was going on there. It was a real opportunity, and I communicated with all of the EIS officers. I correlated the epi-AIDS investigations. I worked with them when they were sent out to do epidemic investigations, and it just brought me in close contact with all the EIS officers as well as the staff of epidemiology branch.
Tell us a little bit more about the epi-AIDS and the role they played and what was included in them.
Whenever someone requested epidemic aid, and it might be a state health officer, it might be, it usually was a state that requested epi-aid. It could have been a medical school or a school of public health that wanted some assistance or someone to aid. It could be a foreign government. And this came in as a request, and whenever a request came in that was accepted, we got a lot more requests than we actually responded to, because some of them were beyond the scope of what EIS was established for. Some of them didn't turn out and didn't look to be significant, and sometimes we just didn't have the resources to do the international travel that other countries may have permitted. But once conferring with Dr. Langmuir, we decided that that investigation should be carried out. Then immediately a memo was produced that was distributed to all EIS officers and to the key staff at CDC. When an assignment was made, those that responded were included. So once an epi-aid memo started, then it was updated whenever there was a significant update, something had happened, enumeration of cases, results of it, and that carried through until the epidemic was absolutely finished, including all the lab work and the conclusions had been done. So it was just an ongoing method to stay up to date on what was going on with regard to every epidemic investigation that was carried out.
And you were able then to document everything that was included in the investigation and the findings.
Absolutely.
And use it for subsequent ones, I guess.
Yes, and often those epi-aids were used as case histories in teaching EIS officers, and that's what made it interesting, because most of those epidemics were not only exciting in terms of the content and how many cases and the severity of the cases, but how they had been analyzed, and sometimes it's very difficult to discover why something is happening, and it's intriguing to be able to have that spelled out in an epi-aid memo. There's a lot to learn just by reading and becoming associated with what was reported.
So it sounds like you would gather the information from the EIS officers that were doing the outbreak investigation. Then would you all meet together and talk about the possibilities and share your ideas about that? How did that work out?
We would if such was needed. Often the people that were out there were doing everything that could be done, but they could communicate back, and those meetings, those councils could be held if there was a need to do so. Mm-hmm. And often EIS officers would call back and say, we found this or we're here, and we would be able to make comments, and I don't really say instruct them, but they were looking for suggestions and ideas and what could be done, and so I could participate in that, but the backstopping was really Alex Langmuir and the superb staff that he had. So each EIS officer out there had the backing and the backstopping, and not only from epidemiology branch, but you had a laboratory branch. You could bring in laboratorians who could tell what kind of specimens would be needed, what to submit them, what kind of media. So all of CDC's resources were at the beck and call of that EIS officer that was doing the investigation.
And you communicated by phone?
By phones, and that was about the only way. Or the only other way you could go would be to go out and visit them.
Did you go on outbreaks as well? And
I did.
Can you remember some of those?
The first outbreak I went on was August, right after I finished the EIS course. The health officer in Arizona reported that there was an outbreak of a undiagnosed disease, but it resembled dengue fever. And I was given the responsibility of investigating that outbreak. We didn't think dengue would be occurring in Arizona because it's a disease usually of the moist tropics where it's warm year-round. But the cases were interesting, and there was a good cluster out in the desert, and so out I went to investigate what was happening. To make a long story short, it was not dengue fever. I was able to pretty well conclude after examining the first group of cases that this was not dengue, and it was probably a disease related to polio caused by an enterovirus. And that's what it turned out to be. It was an enterovirus rather than a polio virus. Being there, the disease was waning anyway. It ended itself. But I was able to reassure them that it wasn't dengue, that the kids would get better. And so if I accomplished anything, it was to diagnose the disease and to let them know that there was little to worry about.
And that was worth a lot to them, I'm sure.
Yes, it was. And then the next month, I was sent to Charleston, West Virginia, Kanawha County, because they reported that they'd had 58 cases of poliomyelitis. And so I went up there to what was thought to be a polio epidemic. It's true that some of the acute cases had mild paralysis, but after a careful examination, this was not polio. And again, I thought it was probably one of the enteroviruses, and it turned out to be an Echo 4 as well. We had wonderful laboratory backup at CDC, and we were able to, again, allay the concern, because there was a lot of concern that this was a major polio epidemic, and just to be able to tell them that this was not polio, that the paralysis would not be permanent, that they would all get better, and mothers and parents felt better, and so we were able to allay the concerns and the fears that were there, and the epidemic, not through anything we did, just waned because fall was coming on.
It was a summer disease, wasn't it?
Exactly.
Mm-hmm. When you were an EIS officer, it was past the time of the Cutter incident. But in working with Alex Langmuir, did you talk with him about that, outside, for instance, of your EIS class?
The Cutter incident was one of the case studies during our EIS class. And so we looked at that carefully during the 6-week course. But I had opportunity on several other occasions to hear Alex talk about the Cutter incident. So I was well aware of it as an EIS officer.
And was it Alex that named it that? Because that's what it's always been called since those days.
Alex always had a way to characterize a major epidemic. It always had a name. And this one, at least by the time I got there, the Cutter incident occurred in 1955. It was now 1959 when I took the EIS course, and It was just the Cutter incident. As soon as you heard that, you knew what he was talking about. It was very exciting and a very important part of CDC's history as well as the history of EIS.
Would you relate some of the salient points about the Cutter incident and what you remembered from your class? How you think maybe it changed CDC?
Let me talk about it first, and then I'll tell you how I think it changed CDC. This episode was one of the big issues of the Tommy Francis field trials that took place in 1955 to see whether the Salk vaccine, the killed inactivated polio vaccine, was effective and safe. 5 vaccine manufacturers were brought together to produce enough vaccine quickly so that the field trials could be carried out. They were carried out in, as I recall, about 38 different states. Hundreds of thousands of children would be immunized in this huge trial. And every mother in the United States, I think, was watching to see what would happen because this was a fearful disease at that time. People were worried about polio. When you think of it, in 1955, before the vaccine trial, there were 58,000 cases in 1 year. And this was something that people dreaded. It was a major disease. With smallpox under control by smallpox vaccine, it was a major killer and crippler. And it was probably the most crippling disease that affected young people in the world. And so when Jonas Salk produced a vaccine, and in small trials he felt that it was both safe and effective, this was big news in the United States. So the field trial was launched. And polio always occurs. It occurred every year. This was April, so it was not the epidemic peak time of year. So one wouldn't have expected a lot of polio cases, but there would be some polio cases at that time of year. But as the field trials began, there were a series of polio cases that occurred in Idaho and a number of other states. There was concern about this, and because of that concern, EIS and Alex Langmuir was brought into the incident. And Alex rapidly sensed the significance of those cases. He sent out EIS officers. They began investigating cases, doing case counts, looking at distribution. And with the data that was accumulated rapidly through the EIS system, Alex was able to speak confidentially that these cases that were being investigated, these small clusters, were directly linked to the vaccine, but not to all 5 manufacturers. He was able to tease out and show that only vaccine produced by one manufacturer was responsible for those cases. And based upon that and the information that he had accumulated, he was able to predict how many cases would occur, how many of those would be paralytic, and he also was able to predict that there would be secondary cases, siblings and other people in the community that would get the polio from that vaccine. And he communicated those predictions as well as his confidential analysis that this was vaccine related. As a result of his being able to do this in a matter of days, he was able to persuade the company to withdraw their vaccine. Ultimately, they would have had to, but it was withdrawn much earlier because of Alex's conclusions. and the certainty with which he expressed his results. And because of what he did, I think the whole nation began to look to CDC as a place that could report disease and do disease surveillance. And if they could do it for polio and do it that quickly and do it that reliably and accurately, then they could do this for other things. And of course, CDC had the competence, but they hadn't been noticed to the extent they were during the Francis field trials.
So that was a beneficial result.
It was
for
beneficial
CDC.
to the public and beneficial to CDC. And now, when we consider the magnitude of the polio problem, it left a significant legacy as a result of these vaccine trials and the disease itself. First of all, I think the public saw clearly that a vaccine could be developed that would stop an epidemic. Within 3 or 4 years after the Salk vaccine was licensed, the number of cases plummeted from 58,000. Within 6 years, there was only 161 cases in the nation, and they were almost all in unvaccinated children. So almost an elimination of that disease within 6 years of licensing of the vaccine. So that was a major contribution to how people felt about prevention of disease. It also had the interesting association that polio was of interest to a former president of the United States, President Roosevelt. And he had been instrumental in founding the
Infant paralysis. The infant paralysis.
Yes, the National Association for the Control of Infant Paralysis, or the Dimes, what was it? The
March of Dimes.
March of Dimes. And so we had the March of Dimes involved, we had science involved, and for the first time, philanthropy became part of disease control. This was the first, there weren't Heart Association and Rheumatoid Arthritis Association. The only one was the March of Dimes, and they played a significant role in vaccine development, vaccine testing, and care of patients with polio. So polio started a new culture with regard to philanthropy and voluntary organizations in control of disease. Out of polio became the really understanding that rehab, physical therapy, could help. It was with polio that physical therapy was used that really improved the performance of people that got paralytic polio. So therapy, which is so common, we have occupational therapy, physical therapy, speech therapy. This really became into front and center during the polio outbreak. As a result of polio, the laws that protect the disabled were enacted soon after polio became controlled. And so the disabilities programs, the changes that relate to construction of buildings, that they have to be able to accommodate the disabled, all of this came soon after polio and Salk vaccine, and then later the Sabin vaccine. So we had a lot of things that occurred in our culture as a result of polio. And then the Cutter incident itself led to a number of developments. First of all, it showed that oversight of vaccine production and safety at the federal level was weak. It was lacking. And so there was strengthening of both FDA and other federal entities in terms of later introduction of other vaccines. And it gave CDC an ongoing responsibility to do surveillance for vaccine preventable diseases so that things like the Cutter incident without CDC being alerted because of people recognizing it for the first time. Now CDC had that responsibility. Other things occurred. There was a flood of legal lawsuits against the vaccine manufacturer. And even though the court held that the Cutter Laboratory had not been negligent, nevertheless the judge ruled in favor of the damaged. So this led to lawsuits. This flood started and has involved lawsuits ever since then. And by the 1980s, lawsuits against vaccine manufacturers were so common that almost all of the American laboratories producing vaccine went out. They dropped vaccines, and most of our vaccines for years had to be imported from European countries because of the legal system. As a result and a fallout of the Cutter incident, we now have, it was I'm thinking to think, the Vaccine Injury Compensation Program was enacted so that a surcharge was placed upon vaccine, not just polio vaccine, but subsequent vaccines. So a small surcharge is added so that people that have a legitimate damage as a result of a vaccine can be compensated if it is shown that it was related to the vaccine. No vaccine is absolutely perfectly safe, but they are so safe in comparison with the disease they're preventing. And we're talking about 1 in 100,000, 1 in a million vaccine-related injury, and that's the price we have to pay, and those that are so injured are compensated. And so a whole culture, a legal culture and disability culture, philanthropy culture have all been influenced by polio and getting polio under control.
When the Cutter incident began, did Dr. Salk was made aware of it, I'm sure. Did he also work with you all to try to find out what the source of the problem was?
You know, I can't really well answer that, but I understand. I didn't know Jonas Salk myself, but he was a person that was somewhat difficult to communicate with. And so there was not a lot of communication during the vaccine development as well as during this period of time.
When you approached the state and county health departments that had polio epidemics and in other situations, how did that work? They requested your help, and then you would go to determine if it was polio, and then what would you do?
Actually, the communication could go two ways. With the two epidemics I mentioned that turned out not to be polio, but one of them was thought to be polio, that was a request from the state health officer to CDC for epidemic assistance. With the Cutter incident, with Alex now being empowered to do something about it, then he notified those health departments in those states where cases were occurring, and of course he got their permission to come in, but all of them were delighted to have help in looking into these problems. So it can go both ways. The state can request it, or CDC, EIS can say, hey, there's something interesting going on. Would it be all right if we sent someone out there to look into it and work with you?
So it was more that they were offering help, not insisting on coming. Is that the way it was?
Mm-hmm.
It sounds like a good system that worked for everyone.
Yes, yes. And I guess if you had a national emergency, I guess there is power that you could require them to allow someone to come in, but I don't know that that has ever been exercised. It's always one of collaboration and cooperation. CDC began working even more closely with state and local health departments after the polio epidemic. Money was appropriated to CDC to help fund and help upgrade epidemiological and laboratory competence at the state level. So I see this relationship as one of total cooperation. It's people working together because they need to work together and because they like to work together.
And you brought up the fact, too, that there were other organizations outside of the government that also helped.
Absolutely.
In different ways.
And that's continued to the present time with I don't know how many different diseases.
Mm-hmm.
And probably, just an aside, the National Foundation, March of Dimes, probably because of their relationship to Franklin Delano Roosevelt, probably had more clout at the time of the Francis field trials for Salk vaccine than any of the current societies have. There was a stronger relationship and more power because they were the only kid on the block that had that role, and they were well funded.
And they had Franklin Roosevelt and Basil O'Connor.
And a whole group of a board, both a science board as well as a board just governing their day-to-day conduct.
Do you remember when the CDC's Advisory Committee on Immunization Practices began and how that started and what it was like?
You know, I know it started in 1964 when that activity, and that also was stimulated by what happened with polio. But I was not with CDC at that time, and I was not closely involved with it, and I don't think that I could add anything on that.
What were your next steps then after you did EIS?
After I did the actually EIS was just the beginning of my relationship to CDC. At the end of my 2-year military obligation, I was offered a career development program where I could go and get further clinical or public health training. And by now I was a convert to public health, and that was of great interest to me. And so I left CDC, still a commissioned officer in the Public Health Service, and completed my residency in internal medicine in Boston, and then was able to get a Master of Public Health degree, and that led to a doctorate in public health from Harvard. Mm-hmm. Then I returned to CDC because I had a payback time.
So they supported you during your fellowship and your MPH, and then you paid back time by working at CDC.
Exactly.
And did you come across some other public health people when you were in Boston names that we might know?
It was interesting in Boston because not only did I become acquainted with the people at the School of Public Health, but Bruce Dull, who had recruited me to EIS, was working in Dr. John Ender's laboratory. And just across the street, Thomas Weller, who was also a Nobel laureate with Robbins and Enders, he was just located across the street. And it was a wonderful privilege to get to know Tom Weller and John Enders, and later Frederick Robbins, and they were three just not only great scientists, but wonderful men. So often Bruce and I would talk together. I would visit him when I had a minute during my residency, and we'd chat while we were in his lab, and I got to know Dr. John L. Enders well.
What was he working on at the time, do you remember?
He was, after growing the polio virus in cell tissue culture in 1949. He then branched out and went into measles activity. And at the time that Bruce was working in his laboratory, he was attenuating the measles virus so that it could be used in a live attenuated vaccine. And that's what was going on while Bruce Dahl and I were talking together in the laboratory. It was interesting to see the people that worked for him, and he was almost always in the laboratory himself, and they were doing passages of their measles virus to further attenuate it.
And I understand that you were interested in that vaccine because you had young children of your own.
Well, exactly. At that time, I had 4 children, and they were all under 10. There was a measles outbreak in Boston where our kids were attending school, and I know they were going to get measles. And so one day I just asked Dr. Enders how he was coming with his measles virus attenuation, and he said, well, it needs a couple more passages, but we're making a lot of progress. I explained to him that my kids were probably going to get measles, and wouldn't it be better if they got it from a slightly attenuated vaccine rather than getting it from wild measles virus vaccine? And I asked him if I might get 4 ampules of his virus, and he said, yeah, help yourself. So I went home and gave my 4 kids measles vaccine when it was in the process of attenuation. And I will say that the epidemic continued in the community. 3 of my children didn't get measles. 1 of my children got measles about 7 days after they received the attenuated vaccine. And it's impossible to tell whether they got it from school, whether that child got it from school or from the attenuated vaccine. But he didn't have it was just a normal case of measles.
It's a great story.
We were very happy to have only had 1 case out of 4.
During the time you were at CDC, you knew Morris Schaefer, is that right?
I knew Morris Schaefer well for a number of reasons, but yes, he was the head of their public health laboratory in New York City. That was probably the best public health laboratory in the nation. So he ran a wonderful, well-qualified laboratory operation. He had had polio during his life and was, you wouldn't call him disabled because he was so mobile and got around and was everywhere. He didn't let his handicap bother him, but he had had polio.
And he and Dr. Lee made a contribution to polio. They determined the different strains, is that right?
That's right. When we talk about polio virus, there are really 3 viruses, type 1, 2, and 3. And it had been determined earlier that there was type 1 and 2, but type 3 wasn't identified until somewhat later. And I think Morris and who was the other person you mentioned?
Dr. Lee.
Yes, had contributed to that identification.
And I understand that he shared the strains that they identified with Dr. Sabin. Do you know did you ever talk to Dr. Schaefer about that or know anything about what happened after that, how Dr. Sabin used them?
No, I don't have any details on that. Where I really got involved with Dr. Morris Schaefer was with the Clinical Laboratory Improvement Program.
Talk a little bit about that, if you would.
Dr. Schaefer was one of the first people that really became aware of problems that were occurring in the nation's clinical laboratories. And I don't want to mean that all clinical laboratories were not doing creditable work, but there were some that were doing sink testing. They would take the specimen, pour it down the sink, and then give the doctor a report.
Without testing it?
Without testing it. And some of them tested it, but didn't have the competence, they didn't have the controls, they didn't have the methodology or the trained personnel, and so the results were inaccurate. They were misleading. And so Dr. Schaefer in New York City was able to get a law enacted so that all the laboratories had to meet certain standards, standards for personnel, standards for methodology, standards so that a glucose or a cholesterol determination from one lab would be equivalent to from another. So there was a standardization between laboratories. So if a patient gave a blood specimen in one lab and then in another, they wouldn't come out different. They'd come out the same because they were using the same standards. And he standardized the work in New York City. Bad laboratories, unfortunately, would just move across the river into New Jersey or Delaware and continue serving the same customers in New York City. And Morris in New York City had no power over those laboratories because this was interstate commerce. And so CDC, and at that time I was working in the laboratory branch of CDC rather than epidemiology branch, we worked together and legislation was written that was then passed by the House and the Senate and became the Clinical Laboratory Improvement Act. And it required every laboratory, every clinical laboratory, interstate commerce, to meet standards with regard to personnel, controls, methodology, and reagents. And I think the United States made a big step forward in standardizing and making sure that clinical laboratory work was accurate and reproducible.
It must have been a huge benefit.
It was, and it was the beginning of this was Morris Schaefer.
And the year, if I'm remembering, was 1967?
Yes.
That passed?
Thank you for that.
Now, at the time that you were finishing your EIS years, would have been the time that Dr. Sabin had introduced the oral polio vaccine. And I wondered if you were privy to any of the decision making that went into talking about whether to get the inactivated or the live attenuated vaccine.
Not really involved in the decision making, but this was a big issue, and probably the Cutter incident really opened the door to the attenuated vaccine. If the Cutter incident had not occurred, there probably would not have been as much support for the inactivated, or not inactivated, but the attenuated vaccine. And I think it went further. Ultimately, the United States and most of the world have agreed that the inactivated Salk vaccine is the way to go. The problem with the Sabin vaccines were that in a number of cases, the virus was able to reconstitute itself, and so we know that cases of polio have occurred as a result of having used the oral vaccine. Mm-hmm. And I think that would have we would have made a decision long before we did had it not been for the Cutter incident. Mm-hmm. It postponed the right decision. And that's not in any way reflecting on Albert Sabin. He started a different line of work, and it worked perfectly with measles, and it just wasn't able to work as well with polio because the polio virus, even when it's attenuated, more easily reverts back to wild stage. It wasn't Albert's fault, and no one can fault him for moving ahead, because had that not been a problem, it might have turned out to be the best vaccine in the end. Mm-hmm. We had to go through that, but I think it took longer.
Mm-hmm. I don't know if you would have been at CDC or in working with polio at all when the vaccine-associated paralytic polio was identified, and what you know about that.
Say that again, please.
The vaccine-associated paralytic polio?
I wasn't working with CDC at that time. I wasn't involved.
Mm. You were one of the few people who worked in the laboratory branch and in epidemiology.
That's probably true.
And apparently there were some ways of working together that worked and didn't work between epi and the lab. I wondered if you had some influence, having been on both sides, with bringing them together in situations.
There were two strong directors, Alex Langmuir, epidemiology branch, UPenn Coco laboratory branch. We know a lot about Dr. Langmuir. Dr. Coco was born in Finland, came to the United States, had an MD degree, as I recall, and was a superb laboratorian. And I think Penty did everything he could to serve Alex and the EIS, but I think it's just under a normal situation, the priorities of one are different than the other. And I don't think there was any ill will between the two. Resources are limited, and you do what you have to do. And UPenn Coco's main responsibility was to serve the public health, the state public health laboratories and city public health laboratories like Morris Schaefer's in New York. And so in his attempting to serve his clients and Alex trying to serve his clients, there may have been a gap in between, and I think therefore that's why Alex felt that he needed to develop some laboratory capability. And I think that's been good for CDC, it's been good for epidemiology, and it's been good for the laboratory. But on 95% of the epidemics, the collaboration between laboratory and epidemiology worked out well and was good and was timely. Mm-hmm. But there were instances where, well, there were determinations that the laboratory branch didn't do that epidemiology branch needed to get done. And so there are both priorities and direction. I think it was a good relationship. And the outgrowth of laboratory services in epidemiology branch was good and inevitable.
You became the director of CDC in 1983. Can you tell us about how the selection process worked and what that was like for you?
You know, that's rather difficult to express because I was selected, so I can't say a lot about the selection process. But I heard from Bill Foege that he was going to step down, and he asked me to throw my hat in the ring. And that was of great interest to me, but it was not the right time, I thought, in my life. We finally had 7 children. We had children in high school. I had some rather significant responsibilities in my work and other things that I get involved in, and it just wasn't a good time to move from Salt Lake City to Atlanta. And so I told Bill that I was honored, and I'd been offered other jobs in both Washington and other places in the East, and I had turned them all down. And yes, I would have loved to have been CDC director, but it just wasn't the time, and that was largely because of family. And so I said no, and that continued over a period of 6 months. So I don't know what the process was. All I know is I kept getting calls, and not just from Bill Fahey, but from a lot of other people. And 6 months after Bill had first called me, I was in a meeting on Long Island. It was a medical meeting, and David Sencer was there, who was the CDC director before Bill Fahey. And Marie my wife, had accompanied me to that meeting. And while we were having dinner together, Dave Sencer with Marie and I, again he spoke on that I should come to CDC as CDC's director. Of course, he couldn't offer the job, but he wanted to interest me in it. And my wife heard that and listened, and when we went back to our hotel room that night, she says, and this is the first time I'd ever had any interest from her in going to Atlanta, she says, maybe you should consider going back to Atlanta. He had, somehow he had touched her. And we made it a matter of further thought that evening, and as we talked about it and thought about it, by the next day we had decided that maybe it was the thing to do. And that was interesting because just before we had left, I was director of the Utah Department of Health at that time, and the very day I left to go to Long Island, I had dictated a letter and signed it in writing, turning down being considered for the position of CDC director. And before I'd gotten on the plane to fly with Marie to Long Island, I had directed my secretary to send it. And she had always done what I told her. And I told Marie, I said, but you know, it's wonderful that we have these feelings, but I just signed a letter on Friday saying I had no interest in the position. Well, we got back to my office. I walked in, and there on my desk is the envelope with the letter in it. And I said to Betty, what is this? And she said, I just couldn't send it. She said, I didn't think it was right. She wanted to get rid of me. But she had never done that before, and she just felt that I shouldn't send that letter.
That's very interesting.
So I sent out another letter saying I was interested in being considered.
And she mailed that one.
She mailed that one. So she got rid of me. And after that, I was called to fly to Washington. I met Secretary of Health and Human Services, Margaret Heckler, was interviewed by her and some of her key staff. And then about maybe a week later, I got a letter appointing me to be director of CDC. Mm-hmm. So that's what happened.
That's very interesting. And it at the time that you were asked to be director, it was a political position, is that right? Because it hadn't always been.
Well, you know, that was one of the great things about CDC, that it wasn't political. It was hidden away in Atlanta, away from Washington, and that's why it grew and thrived, and where it could be excellent. That scientific integrity was the only consideration, and it was still that way. No one asked me what political party I belonged to. I don't know Senator Orrin Hatch, who's still in the Senate, the oldest, longest serving in the Senate. I don't know whether he put any word in for me. I didn't ask him to. I don't have the slightest idea whether there was any role there, but if it was because someone in Health and Human Services asked him. But I don't know what role he played. But as far as I know, it wasn't political. Mm-hmm. I hope it wasn't. I didn't have any political clout. I was working for a Democrat governor of Utah, so who knows?
It sounds like it was meant to be.
Maybe so.
You had some interactions with C. Everett Koop, too. Can you talk about him a little
Yes,
bit?
I'd be happy to. I didn't meet C. Everett Koop until I became CDC director. And of course, CDC director spends about as much time in Washington as he spends in Atlanta. And so I quickly became acquainted with him. And then I became acquainted with him when I became Assistant Secretary for Health after I was CDC director. And got to know him well. And in fact, I was acting Surgeon General until he finally was confirmed. It took a long time to get him confirmed because there were a group of people that were opposed to him. And so his confirmation process was long. So I served as acting Surgeon General until he was confirmed. And after he was confirmed, the Assistant Secretary for Health supposedly is the boss of the Surgeon General. So it was that kind of relationship. But he's a neat guy. I enjoyed him. Surgeon, former surgeon, pediatric surgeon, I think well motivated, best of, I have good feelings about him.
Mm-hmm.
I think he did a magnificent job during the AIDS epidemic.
Mm-hmm. When you were director of CDC, shortly before that was when smallpox was declared to be eradicated from the earth.
In 1978, about the same time that polio was eradicated in the United States.
Mm-hmm.
Smallpox worldwide, polio USA. Yes.
That was quite a time. Do you think that had anything to do with then the goal to eradicate polio globally?
Oh, I'm sure it did. If that had been unsuccessful, then I doubt that the others would have had the dream to do the same thing with polio. And it's really a shame that we haven't been able to accomplish it with polio, because it isn't biological problems. It's, well, maybe it is biological. It's people's inability to get along with each other, because we have all the scientific resources whereby polio should and could be eliminated, and it will be.
And do you feel that that's a worthy goal?
Absolutely.
Mm-hmm.
I mean, why should we keep giving polio vaccine?
Mm-hmm.
Why should we continue to have children and adults crippled with poliomyelitis? Why do we even need to worry about this disease? It needs to be put in the same drawer that smallpox is in.
Mm-hmm. While we've been talking, I wonder if you have thought of other unusual circumstances under which you worked that would be related to polio or AIDS or smoking or any of the other issues that you worked in that you feel like would be good public health messages.
Let me just mention one on polio, because that's our focus. I served a mission for the Church of Jesus Christ of Latter-day Saints in Denmark. And I was in Copenhagen in 1952 when they had their big polio epidemic. And I saw polio from the standpoint of this modern European nation. And they did not have enough iron lungs to take care of all of the people with respiratory difficulty because of bulbar polio. So in 1952, they had young adults and children who couldn't breathe that had to be ventilated by people bagging. They literally had people 8-hour, well, not 8-hour shift, but just taking shifts and bagging respiration to keep people alive in that outbreak of the disease 3 years before salt vaccine was licensed. So I saw the impact. I had seen the impact of polio in the United States, where I saw 35 iron lungs in Salt Lake City. There must have been hundreds of them. An iron lung cost $1,500 when it was invented in 1930. You could buy a house for $1,500 in 1930. So this was only equipment that a rich country could provide to its people. And even Denmark, a modern country, in 1952 didn't have respirators and had to be human beings pushing a bag to keep them alive. Well, what do you think was happening in Africa or India or other countries like this? So when we don't eradicate a disease like smallpox or polio, even though we might be able to get iron lungs, and we might be able to find the rehabilitation to help people to recover from, or at least overcome some of their paralysis, but for most of the world, we're confining people to death or to severe disability. And that's just another plea for let's get polio eradicated. Because we might be able to manage it, and we haven't had a case because we keep our defense up with immunization. But look at the people that don't have those blessings.
And speaking of vaccinations and opportunities, what would you say to the anti-vaccinators if you could give them a message that you think they would hear?
I would take each one of them back 50 or 100 years and take them to a hospital or a cemetery. And I'd let them talk to mothers who have children dying of smallpox or polio or diphtheria. And I don't hold anything against them. They have these fears, these concerns. But I really I'm aghast that there would be people that would prey on those fears and promote those fears. And the internet has made such promotion so easy and readily available. When I was involved in public health, we were striving to get the inner cities immunized. This is where polio and measles and mumps and diphtheria were occurring. And today, public health has triumphed over the inner cities. We've been able to get the vaccine to those wonderful people, but it's the well-to-do and the educated that get on the internet and share these fears that are so unfounded. And I feel sorry for a mother who's so deluded that denies this kind of preventive help to their children and encourages others not to use it. They need to really recognize how severe, how far we'd be going back. And their children are being protected by herd immunity because others are being immunized. If everyone stopped taking it, it wouldn't be long before they'd want vaccine.
That would be a great message. You've had some other high-profile jobs besides those at CDC. Would you tell us about some of those and some of the work that you did in those jobs?
Well, yes, I've had a lot of them, and so I'll be brief. I left CDC once to become a epidemiologist and infectious disease specialist at a hospital in Salt Lake City, the LDS hospital. And spent a year doing that, and then CDC lured me back as deputy director to David Sencer. So I enjoyed that job, and I made a number of attempts to get into clinical medicine, but I never lasted there because something else came up. So I spent a year as CDC deputy director, and then the LDS Church asked me to come out and manage the hospitals that they owned in Utah, Idaho, and Wyoming. And so I left CDC and came out and did that, and spent from 1970 to about 1972 managing the hospitals. And in that, what I did was took 15 hospitals and bound them together as a multi-hospital group. And then I was able to talk to the leaders of the church that it really shouldn't be in the hospital business. It didn't need to be in the hospital business. It wanted to take care of the poor and the sick and the needy, and there was no advantage to owning or operating the hospitals. Others could do that better, and it diverted them from their religious responsibilities. So we created Intermountain Healthcare, which is the biggest multi-hospital group around here. It has grown since that time. So I worked myself out of a job after working for about 7 years as a hospital executive. And then I became head of the Utah Public Health Laboratory. So I went back into the laboratory business and did that, and then joined the University of Utah as the head of Family and Community Medicine. And then a new Department of Health was created in Utah, and Governor Matheson asked me to assume the position of Executive Director of the Utah Department of Health, and I did that for about 5 years and then became CDC Director. After I left CDC, and I left because I had become very friendly with Dr. Lewis Sullivan, who was the president of Morehouse Medical School. And CDC had always had a close working relationship with Emory, and of course that was very profitable for both entities, but I wanted to make sure that Morehouse was more closely wrapped into CDC, so Lou Sullivan and I became well acquainted. And when he became Secretary of Health and Human Services during the first Bush administration, he asked me to come up as Assistant Secretary for Health, to be over the Public Health Service. And I had done that in acting capacity while I was CDC Director for a year. And so it was easy just to move to Washington and step into that position. And I did that until President Clinton was elected, and then everyone handed in their resignation, and I handed in mine. And so I left there, and I retired. And after I got back to Utah, I was called to a position, it's called a 70, and assigned to Africa for 5 years.
For the church?
Pardon?
For the church?
For the Church of Jesus Christ of Latter-day Saints. And I served there in more of an administrative position. I was responsible for missions and missionaries and ecclesiastical matters, but there was a lot of spare time. I gave a number of lectures on AIDS and on public health at medical schools in Africa, and saw patients, and so it was a very fulfilling, wonderful experience. And Marie and I were in Africa for 5 years, and then I came home, and it was not long after that that I was asked to be part of a long-term care association, Avalon Healthcare, which is headquartered in Salt Lake. And I moved from its board of directors to becoming president and CEO of that for a number of years. And while I was there, I established Bristol Hospice, and it grew, and now we have Bristol Hospice from Georgia to Hawaii, and it's become bigger than Avalon Healthcare. And I did that for a few years, and then I really retired. And since that time, I've served on some boards, but I do more work with family and family history than anything else now.
Well, that sounds like a wonderful place to end up, and I have enjoyed so much hearing all of your experiences and how you used all your skills, and it came together to help all of us. So I want to thank you very much for participating in this oral history project.
Thank you for giving me an opportunity to talk to you. You're a wonderful interviewer.
Thank you.